Hi everyone, my name is Melanie Grant, and this is C&M Class. Today we're looking at coding with ICD-10-CM Infectious and Parasitic Diseases, Coding Chapter 1 for A00 through B99. And this is part one of two parts for this video where we talk about infectious diseases. We're going to be looking at our key points for sequencing, looking at code first versus code also or use additional, the differences of coding with an infection and a bug, what to do when we have drug resistant, and how to look at some of those exclude 1 and 2 codes. We'll look at several examples from our guidelines today, so we're going to break this up into two parts where we first look at some of those guidelines and then practice some of those together. So let's get started. The first thing I want to look at is what books I'll be using for today's lecture. I am in the ICD-10-CM 2021 code book by AHIMA, and I'll also be referencing my textbook, which is from Elsevier, the Carol Buck's 2021 Step-by-Step Medical Coding. If you have a different edition or a different year, feel free to follow along, but pay attention to some of the coding differences you may see or differences in guidelines. We'll also be looking at guidelines only pertaining to A00 through B99, but there is some references for COVID-19. I have another video where we talk about how to code for infections with COVID-19 and looking at those COVID-19 specific instructions and guidelines that were released this year in 2021. Make sure you follow that in the comments or in the links below. Looking at A00 through B99, in my code book at the very beginning of my coding tabular, I have a couple of really cool references I'd like to point out. Yours may be a little different, but make sure to look into your guidelines if you don't have this in the same area. The first thing I have is an instructional notation that just reminds me what some of my terminology means when I'm looking, for example, at exclusion 1 and exclusion 2 notes, as well as some of the references for code first or use additional. The thing to keep in mind is when you see an exclude 1 note, it means not coded here. So that should not be coded together with another scenario. We do have an example of that in our coding chapter section A00 through B99 at the beginning of the chapter, meaning to all of the codes in this chapter, we have an exclude 1 that says certain localized infections should be coded directly to the body chapters. What that means is there's a difference between a localized infection and the bug itself. When you're going to be looking at the bug itself, you always code for A00 through B99. As we look at some of the examples later on, we'll see how we can have use additional or code also or code first notes to identify when that applies. The other thing we want to look at is excludes 2, which really means just simply not included here, meaning you may have both of these occurring at the same time, but don't come here for that. Come here if they have both scenarios. And we have that listed for an excludes 2 note that says carrier or suspected carrier of infectious diseases not included here. Instead, look at your carrier codes for Z22 dot breakdown. We also have listings for perinatal patients, as well as pregnancy patients who should be coded to either the P codes or the O codes, respectively, based off of where they're, what affects them. Remember, your perinatal patients are going to be 28 days and less, and your pregnant patients are, well, as it says, patients who are pregnant. The other one that we have an excludes 2 note for is influenza and other acute respiratory infections, which are found in your J00 through J22. We'll look at some of those specifics when we code for some of the examples today. That allows us to get started looking at the coding chapter for A00 through B99. The first thing we look at is that there's 2 different codes here, or code sections, from A codes and B codes. And I'm going to reference our textbook here because I think it has a great reference of what those differences are. Under your A codes, you have several different blocks. If we look at these are specific to intestinal infections, tuberculosis, certain zoonotic bacterial diseases, other bacterial diseases, infections with predominantly sexual mode of transmission, other spirochetal diseases, don't tell me if I said that wrong, and other diseases caused by chlamydia. Most of these you'll notice, and rickettsiosis, and viral and prion infections and other of the central nervous system, and last but not least, arthropod-borne viral fevers and viral hemorrhagic fevers. Whew, there we go, that's all of them. Most of these are listed in your A codes, are bacteria and a couple of viral. And there'll be some very specific guidelines when you're looking at some of these as we go through, specific to sepsis, septic shock, severe sepsis, and SIRS. In the B codes, our definition is a little more clear. B codes are going to include your viral infections, your fungal infections, microscopic animals, parasitic worms, louses, mites, and other infectious agents. So when we talk about parasitic diseases, we're thinking of little bitty tiny things that can get into the body and wreak havoc on the anatomy and physiology of the human system. So that kind of helps us to look at, even though there's some viral in the B section, a lot of your viruses are going to be found in both. Your bacterias are predominantly in your A codes, and your virus and other fungi and fun stuff, not so fun, found in your Bs. That being said, the first thing when you're looking at your coding section is really look at the term infection. When I think about infection or infectious, I want to go to infection first because a lot of the different codes are going to be referenced either A's, B's, J's, wherever you need to end up coding. You're going to find it first by looking at the infection and then moving on. If you have a specific type of term, you may look up that term first, but always keep in mind the subterm infection even when it's not stated. When we talk about your main term, this is one of the ones that's going to get you to your coding the fastest. If I look at infection in my alphabetical, I'm going to see that infection starts on page 186 and it carries for several pages in all kinds of different infective areas all the way to the top and last column of 190. This is a rather large area, but if you look through it, you'll see several different references that have A codes, B codes, and various A through Z, depending on what coding chapter it should actually go to. So how do I know when it's going to go somewhere else? Well, there is a couple of references that you can keep in mind. You're always going to code first if you have a pregnant patient, because that's going to be a patient who should code into your O sections, but you may end up having your category for a pregnant patient in addition to the category for the infection. You're also going to be looking at other areas for things like influenza, respirations, and localized infections, remember, will be to the localized area. And then, of course, with COVID-19, you want to look at specific guidelines for those, even though COVID is a viral infection and would typically be part of your A through B category. This one has its own unique coding with its own specified coding guidelines. In fact, I have a separate video talking about COVID-19 that you can reference. In the A and B codes, you have a couple of very specific ones in your guidelines, such as HIV conditions, sepsis and SIRS, and MRSA. There's a couple of smaller ones too, but mostly what it says is when you're coding the bug, only code the bug if it's confirmed. That's one of your big things, only coding confirmed, even if it's inpatient. And remember, the reason for that is your A and B codes are talking about the bug, not the problem. With HIV, there is one exclusion where if you have an inconclusive serology, meaning a lab test that's come back as inconclusive, there's a code R75, which would indicate that we think they have HIV, but it's not conclusive, it's not positive, it's not certain. Otherwise, in HIV patients, you have different codes for conditions where a patient who has signs, symptoms, or other problems caused by HIV, and codes for secondary problems. Our HIV guidelines tell us that if a patient's being seen for a condition that is caused by HIV, we always code B20 first, followed by the actual condition that they're being seen for, or signs and symptoms. If the HIV patient is seen for something that is not HIV related, but they happen to have an HIV condition, that B20 is still listed along with the conditions that are being treated, but it's listed as secondary. If they just simply have HIV, it's confirmed they have HIV, it's not currently active, then you're going to code for code Z21. And those are going to be referencing in your coding guidelines, section 3.C.1.A, all the way from section 1 and 2 in selecting the sequencing of HIV guidelines. There is a specific guideline for pregnancy patients where you will have a specific pregnancy code with as primary, and then either your B20 or your Z21, depending on what is relevant. And there's a Z code specific for screening for HIV when a result is not in, where you will use the screening for human immunodeficiency virus and then any additional codes that may have caused the reason for that screening. In your sepsis guidelines, we also have some very specific rules and regulations. That one's maybe a little more intense. Again, we only code what's confirmed, so if there's something that's suspected in the documentation, follow your query processes to ask your doctor and say, hey, you mentioned this and you mentioned this other thing, but would possibly sepsis apply? Does it not apply? Always query your provider with an open-ended question. When you're looking at sepsis, this one's going to be a unique guideline because there's different rules depending on if the patient has sepsis, if it's documented as severe, if there's the term septic shock, and if it's SIRS. The first thing I want to talk about is SIRS. What's the difference between sepsis and SIRS? Well, I'm glad you asked. If you look in your tabular on R65.1, which I'll have a page number for you in just a minute. I'm going to find that on page 952, 951 of my book is where it starts, at the bottom of 951. R65 category is for symptoms and signs specifically associated with systemic inflammation and infection. If you don't know the terms and what they mean, when we talk about systemic, it means it's affecting the entire body. Inflammation means that the body is inflaming or responding to something, and it could be caused by an infection, or it could be caused by not an infection where the body's just shutting down. R65.1 identifies systemic inflammatory response syndrome, or SIRS, of non-infectious origin. What that means is there's not a bug. You would not be looking at codes A and B. You would instead be listing R65.1 and then any additional breakdown. So R65.1-, so your category R65, this is non-infective. And it's important to remember the term infective or infection is referencing a bug. So if it's non-infective, there is no bug. At that point, there is a couple of notes. So you have some guidelines here. It says code first the underlying condition. So what caused them to have SIRS? It could have had it from a heat stroke, an injury, or trauma could have occurred. And so those are both listed as some of your code first underlying conditions. There's an excludes one note for sepsis. So if they have sepsis due to an infection, you're instead going to look at R65.2 when it is severe, or just sepsis by itself, which we'll talk about in just a moment. You also have the differences between R65.10, which is non-infectious origin of SIRS with acute organ dysfunction, without acute organ dysfunction, and R65.11, which is SIRS with acute organ dysfunction. And so what they mean when they say dysfunction, they're talking about like organ failure or potential organ failure that's clearly documented, and they give some different examples. Now, the reason I look at SIRS first is because it's important when you're looking at sepsis to, in fact, verify that it is an infection. Even if we don't have the cause or the bug, we want to make sure the provider is clear in their documentation of that cause. Now, with sepsis, we have a couple of different guidelines. The first thing we want to look at is the first thing that we look at is A41 category. Let's go there first, and we'll look at the guidelines back in a moment. You'll find A41 starting on the bottom of page. I just had it. 482, nope. Yes, 482, which says other sepsis. Now we start here with A41 because most of the time the sepsis is listed as generalized. Most providers don't know the bug that caused it, but they know it's infective, and so they'll call it sepsis, but they may not have listed the type. If it's unspecified or not otherwise specified as the type, A41.9 is the appropriate sepsis code, and that's what's listed in your guidelines. But if you look at this, you actually have a couple of references in A41.0 through A41.4 that talk about specific types of sepsis. You also have an excludes 1 and excludes 2 note. Excludes 1 includes things like bacteremia, neonatal conditions, and peripheral sepsis, which are pregnancy or perinatal patients, which of course we should know go to a different area. We have an excludes 2 note for sepsis that is due to specific bugs. And this lists a whole list. You can look at that yourself. It's on the top of 483 of my book, or as the excludes 2 note for A41. Once you've identified that, yes, you would in fact be in category A41 for other sepsis, you have a code first note. And this is talking about the condition that causes the sepsis. Now, in this instance, you may not have this, and it is appropriate if a specific type of cause for the sepsis is not listed. So you have options for post-procedural, labor, abortions, ectopic or molar pregnancies, immunizational, and other transfusion or therapeutic injections. If the patient does not have sepsis due to one of those reasons, then your primary instead is going to just be your A41. So you want to look at your primary or secondary is going to be your A41 unless a specific condition applies. Once you've identified that, it's important to say, is there organ dysfunction included? The reason we look at this, even if it's not documented in by the provider, is that there is documentation that indicates here a code from, this is under your coding guidelines under sepsis, severe sepsis 1.A, and it says in the second paragraph, a code from subcategory R65.2, severe sepsis, should not be documented unless severe sepsis or an associated organ dysfunction is documented. What this means is if the provider indicates that there is sepsis and let's say they have respiratory failure, which is a severe organ dysfunction, then code R65.2 would be listed. Now that's not your only one. You have your primary here and you have your secondary, but you're also going to list a third code for the organ dysfunction. So let's look at that again. We have a patient who is being seen for severe sepsis. We first need to verify that it's not SIRS. We then need to verify that if it comes to category A41 and or if there's a condition. So what caused the sepsis? Do we know? If we know, list that as well or list that instead. Determining the primary, we then say, is there any kind of organ dysfunction documented? If there is, then we list R65.2 because it's severe, and we list the organ dysfunction that qualified that. So we can have anywhere from 2 to 4 codes for the documentation of sepsis. So you can see here in the notes I've given you, sepsis is a primary by itself when there's not a listed reason of A41 dot. If it's SIRS, it's not infective. Instead, look at R65.1. If it's severe, identify the infection or A41.1, then the severe code and organ failure. The term septic shock should be documented by the provider. That means that there's a circulatory infection. It's spreading. It's causing the entire body to start shutting down. It's typically identified by more than one organ failure. In the past, I've seen it with 3 or more, but that's no longer in the documentation or referenced. You want to look and see if the provider has indicated septic shock. If they indicated septic shock, this is going to be a breakdown of R65.2, identifying with or without septic shock. The last one we're going to look at today as part of part 1 is your infections with MRSA. When you have a patient who has MRSA or MRSA, there's going to be 2 options for your codes. You have either a combination code, which is going to be listed as examples on page 477 of my book or in your coding guidelines under section 3.C.1.E. 1.E, which is going to be for your methicillin-resistant Staphylococcus aureus or MRSA infections. There's guidelines here for combination codes for MRSA infections, which basically say that if there's a combination code, you should not also code the code for MRSA. You should use the combination code only. But if there's not a combination code available, you would use first the condition or problem, and then the bug, the B code, for the MRSA. There's also a separate code that's listed under the secondary conditions that say that there's a carrier code for MRSA, which basically follows the same guideline we've already looked at in our excludes 1 note for this entire coding chapter, that if they are a carrier without a current condition or infection, we use instead Z22. The last thing in the guidelines talk about is the Zika virus infections, which basically just say to only code it if it is confirmed case. So we want to make sure that when we have a suspected condition, unless they have guidelines on what to code, always code your bugs only when it's confirmed. That's it for this part 1 of part 2 video. Make sure you check out our secondary video where we're going to look at some of the specific guidelines when coding for respiratory infections, and we'll do some examples together to see how the bug works along with other coding chapters. We'll see you on our next video.